Starting to record. Good evening and welcome to Thursdays with NAMI. My name is Peg Morrison. I'll be your host for tonight. I'm the Director of Programs with NAMI, North Carolina. That's the National Alliance on Mental Illness, North Carolina. Thursdays with NAMI is our way of building conversations and building community on the topic of mental health. I'm glad you're here. If you're familiar with mental health care, you have heard this story. A child or an adult has a mental health challenge, they have a breakdown, they get hospitalized. When they return home, they end up waiting months to see a doctor. What is that about? Well, there's a serious shortage of psychiatrists in North Carolina and across the country. Unfortunately, the Association of American Medical Colleges expects the situation to get worse before it gets better. So how can people get the medication they need? Enter psychiatric mental health nurse practitioners. We have 3 of them here tonight. They're leaders in the field, and I'm so excited to have this conversation. They have specialized master's and plus level training that allows them to treat the mental health needs of their patients. That includes prescribing psychotropics. What is a psychotropic drug? That's a medication that affects one's behavior, mood, thoughts, or perception. In other words, it can enhance our mental health. Tonight, we'll be talking with 3 of them. What are they seeing on the front lines of mental health? What insights can they share? We'll be learning more about that in just a moment. As usual, the first part of our show will be a conversation with our esteemed guests. About halfway through, we'll show a video of the week, and then we'll spend time answering your questions, virtual studio audience members. Now, I've got a quick word from our sponsors. Thursdays with NAMI is funded in part by the North Carolina Department of Health and Human Services, Division of Mental Health, Developmental Disabilities, and Substance Abuse Services through the Substance Abuse and Mental Health Services Administration. It all stems from the Federal Community Mental Health Block Grant Fund. Boy, is that a mouthful, but we are so grateful for their guidance and support. All righty. Now, without further ado, we're going to be talking to our guests. LaTanya Clark-Chalmers practices at a community mental health clinic where her areas of interest include integrative health and healing therapies and partnerships with faith-based organizations. She believes in the power of compassion, diversity, equity, and inclusion. A native of Suffolk, England, we have Angie Trombley. She's a doctorate and is a family psychiatric nurse practitioner, allowing her to care for the mental health needs of her patients across the lifespan. She's the current vice chair of the North Carolina Nurses Association Psychiatric Council. She lives in the Asheville area. Susan Weber is a psych NP, and she became that in 2010. In 2017, she moved to the University of North Carolina School of Medicine Psychiatry Department as clinical instructor. She also serves as adjunct faculty for their School of Nursing. Susan works with both the inpatient and outpatient populations. I know you all have more accolades than that, but I try not to have a book each time I introduce someone. So feel free to fill me in and make corrections. I know there's more to say. Thank you all for being here.
Thank you.
Glad to be here.
Yeah, so we always start with the same first question. We like to understand the backstory of our guests and what brought you here tonight. So tell us about yourselves in a nutshell, and we'll just go alphabetically by the last name, LaTanya, Angela, and then Susan, if you don't mind.
So what brought me to my career in psychiatric mental health nursing?
Mm-hmm.
Actually, I have an interesting story. I came to nursing later in life and was actually thinking about pursuing a career to be a licensed clinical social worker. And I have a close relative and friend who is a nurse and an advanced practice nurse. And she said, "Have you ever thought about being a psych NP?" I said, "A what?" So she explained what that was, and I did some investigating, and it felt like it was the right fit, and it has been the perfect fit. In fact, one of the things you'll find out about us tonight is that we believe in advocacy for our patients and advocacy for our profession. And so I had out of town and had come back for something. And my relative said that I needed to go be with my people. I said, what do you mean my people? So there was the NCNA Psych Council retreat. And that's where I met Susan, my people, meaning other psychiatric health nurses. So yeah.
Well, that's wonderful. Thank you for that.
So with me, I was fortunate enough to have a very early experience that, was very fundamental for me, that kind of led the way on this career path. When I was in England, I graduated high school at 16, and I applied to nursing school, but I couldn't start until I was 18. And so I found a job in this fantastic scheme. At the time in the UK, they were engaging in Care in the Community Act, where individuals who had been in these institutions for many, many decades were moving into home environments. And so I worked in a home with 6 older men, and we cooked together, we ate together, and I had an education that you would really never read about. It was the lived experience, and they were sharing with me of their experiences. Some of them had been in what was known as the mental hospital, and before that, the workhouse for decades, maybe their whole adult life. And so I learned about some of the treatments that they've been through, and the padded rooms, restraints, and unfortunately sometimes some physical abuse, and the just the very adverse experiences they'd had. And it was then at such a young age, I learned about the stigma, discrimination, and the huge vulnerability with this population. There was one day that I took one of the clients out. Some of our role was being a key worker, and so we went out shopping in the high street, and we would go out and get something to eat. And we were walking along the street, and I was linking arms because he was a little bit unsteady on his feet, and I wanted to keep him close. And he was talking really loud because he was so excited about being out, and people were looking at us, and he didn't care, and I certainly didn't care. And in that snapshot of time, I remember looking in his face, and he was so happy, just beaming with this experience, with these bags in his arms, and we're about to go and get some tea and cake. And I just thought, I learned about resiliency, and I learned about hope. There was so much more that they gave me at that time, and I realized this is exactly where I need to be. That was, my compassion was right there, and I'm like, I need to do anything in my power to improve the care that these people get. So it was super early, and I'm super fortunate to have been privileged enough to work with and meet those people.
That does sound like an aha moment, as we say in NAMI.
Absolutely.
That just seeing that someone could have that joy for being outside and being a part of.
I think that the 3 of us probably love nursing first, and that's given us all the groundwork to be able to do what we do best as psychiatric nurses and nurse practitioners. The therapeutic relationship on a med-surg unit is as important as a therapeutic relationship on a psych unit. I started long ago just thinking I was going to be a peds nurse, had an opportunity in Boston to work as an internship at Tufts Floating Hospital. They for a summer internship, and all they had was a med surg, and I about died after week 2 on that. And they were opening up a child psych unit, and they allowed me to move my internship to that. And that was late 80s, and it was such a collaborative time. It was amazing how everybody worked together to figure things out. It was not a hospital the way things are now at all. So I loved that. I was a young woman, but I didn't want to stay in Boston, came back to the South, and really saw nothing like that in the South. Peds nurse, and then did other nursing things. Nursing's a very varied opportunity. I'll cheerlead nursing. You could do anything you want in it. I did that and stopped for a bit and raised a family. And when my kids were in elementary school, by then we had moved to Raleigh, and decided I wanted to go back, and just kept thinking about that Boston experience. And so I went to Dorothea Dix and worked there on the adolescent unit for a few years. saw the writing on the wall, obviously, that outpatient world was going to be the next world, and was thrilled to find out that I could have the opportunity to impact that in a different way than psych nurses can in an outpatient environment. That's very rare to see that. So went to UNC and then worked in the community for 7 or 8 years in Durham. Was part of the NCNA Council too during that time, trying to get more and more psych nurses and advanced practice nurses together. And then was recruited by UNC and went back to inpatient work for part of the time, and did work with adolescents on the inpatient unit. And then since COVID, I've gone full-time to outpatient again on Zoom. Sometimes I do admission work at UNC still, but that's kind of where I am now, is doing outpatient peds and adolescents. Certainly a heartbeat, but I see all ages now.
Well, I understand the shortage of child psychiatrists is especially critical, so you must be very busy. I'm sure all of you are, but.
Oh yeah, it's definitely, and I think Angie does a lot also with child and adolescent. So, and on the western part of the state, I'm not sure, Latanya, if you do child and adolescent, but certainly there is a huge backlog for treatment for them, and access. Not just backlog, but access just to even get close to them.
Right. So we'll start with Latanya and move into our nuts and bolts questions. How is mental health nurse practitioner different from a psychiatric nurse or a psychiatrist?
So Susan, Angie, and I are all psychiatric nurses, but we are advanced practice psychiatric nurses. We're all PMHNPs, or psychiatric mental health nurse practitioners. And so when you think of RN versus an advanced practice RN versus a psychiatrist, you look at the training for those particular specialties. And so for an RN, there are different routes to that training. You have RNs who have PhDs, who have EDDs, and have other advanced degrees. But for psychiatric mental health nurse practitioners, we have at least a master's degree and then have specialized training in psychiatric mental health nursing. Dr. Trumley actually has a DNP to be a PMHNP. And so I'm going to be just very careful here, because I don't want to get into a debate about psychiatrists versus PMHNP, because in the state of North Carolina, we are not full practice, which means we cannot practice within our full scope. And as part of that, in order to practice, because of the rules, we have to be connected to what's called a collaborating psychiatrist.
Right.
And so whether a PMHNP or a psychiatrist, we both can assess and diagnose individuals with mental health diagnoses. We have treatment where we provide medication management, order, interpret labs, all of that. But the piece that makes, I can't speak for psychiatrists, but I can speak for PMHNPs in the way that we approach care in that holistic way. The way that we care and we see our role as caring healer. And so with that, we understand that recovery looks different for different people. And the goal of recovery, sometimes when you hear the language of recovery, sometimes people just only think about substance use disorders or addiction. But when we think of recovery, we think of how can we help the individual live their best life? And best life looks like different things for different people. And so PMHNPs, psychiatric mental health nurse practitioners, are uniquely qualified because there's so many things that come under our umbrella of practice, where we can do the therapy piece, the med management piece, the motivational interviewing, all of that. But to see the person as a whole, to help them live their best life. We excel at that.
Mhm.
So I don't know if that answered your question or not. I can elaborate, but yeah.
I think that covered it. So Angela, Susan, would you like to follow up on that at all?
The only thing I'd say just to clarify it is a psych nurse practitioner comes generally from nursing. So we have an experience that comes up from nursing. A psychiatrist comes up from med school. We come up from nursing school. So our modality starts in the base of as an RN, and then we move up that way. And psychiatrists would be School of Medicine, and they move up their way. Of course, the way the different modalities, a lot of us are taught a lot of the same things, but their focus in med school is a much broader focus because they are learning, all types of things that are not just psych specific. And in part of our practice, we have to learn about diabetes, cardiac things, all of those things as well. But our focus also is on the psychiatry aspect of it when we get our advanced degree. And we work with psychiatrists all the time. They are all good friends. They're all, it all works out. It's just that the way that we all go through school is just through different schooling and modalities.
Well, being with NAMI, of course, I'm a big fan of the grassroots and maybe having more of that frontline experience. It seems like that could only be a good thing. Angela, did you have a comment? I think you may have been muted there.
Oh, okay. Yeah, I was going to add, completely in agreement that is that therapeutic alliance and relationship that is sometimes just such a vital part of what we do as a psychiatric nurse practitioner, and the ability to listen and really see somebody in their life and in that moment in time in that holistic way. And sometimes I'll have somebody just tell me, they feel so much better because I've sat and listened and empathized and been there present with that person before I've even prescribed a medication or done anything else. It's just that presence that we provide. And I think it's absolutely that nursing experience that brings that to us.
Wonderful. So our next question, we touched on it a little bit. We hinted at it. And this goes to you, Angela. How much autonomy do nurse practitioners have in North Carolina as compared with other states? And maybe you could also say a little more about that presence that you bring to the table with your patients that might be different.
Mm-hmm. So as regards autonomy, and unfortunately, as Latanya had mentioned, we are limited compared to some other states. So this very specialized, one of the specialized roles that nurse practitioners can do is we can provide wider access to care. We can engage in rural healthcare, but in this state at this time, we are limited because of the collaborative practice agreement that's required of us that it's not in other states. And actually the law in North Carolina hasn't really changed too much in the last 40 years. However, there is the SAVE Act, and so legislation is looking at widening our ability to practice and provide that quality healthcare that we can do within our scope and expertise. And also, the bottom line is people are looking to decrease costs associated with health care in general, and that would be a way to do it. If we can widen our access and patients' access to us, and we can go out to some of the rural areas where some other providers don't want to go, perhaps we can actually help with reducing healthcare costs, because of course you're going to have less people going, in acute crisis, and some of the hospitalizations that are unnecessary if we provide that care in the outpatient setting.
Well, absolutely. I think we all want to reduce healthcare costs for sure. Mm-hmm. Any follow-up comments, Susan or Latanya?
I think it's interesting. The collaborative agreements look different across the country. There are about 26 states that don't have them now. The collaborative agreement in North Carolina says that we have to have a signature by an MD that says that they will be our collaborating MD. We do not have to pass we get to choose what meds for a patient. We get to choose what type of therapy we think is important for a patient. We don't pass that through that physician to get approval. We do all of those things, and that relationship is such that in the beginning, when you're working with them, you meet with them once a month about things that might be issues or concerns you might have about a patient, and try and collaborate on what the best things are, or if there's something that comes up. So the idea behind it is that you have a relationship to lean in. It's a formalized relationship to lean into a psychiatrist. Our take is we would do that anyway, because whatever's best for the patient, we're going to go do that, and don't need a piece of paper signed each year. Some physicians charge nurse practitioners up to $10,000 a year in order to be there collaborating. So our nurse practitioners that have their own practices may have to pay up to $1,000 a month for this piece of paper and this conversation on a month-to-month basis. So we are working hard not to decrease care, quality of care, anything, but to say, let us practice to our full authority. And we will use you. We call cardiologists all the time when we have trouble with something. That's what you're supposed to do as part of care. One other quick thing that might be confusing to people that I think is important is a PA and an NP sometimes are lumped together in many ways. And a PA is a person that may have had a science background or may not have, but has gone and gotten a master's as well and learned how to do clinical work through all the different modalities like you would in a med school. So they go through 6 weeks at a time of different modalities. And then much of their training is they have to be signed on to a physician. So whatever physician they choose to go to, whether it's dermatology, psychiatry, etc., they leave that. So the PAs and NPs are sometimes called mid-level providers, and you may see them in all kinds of practices. Again, we are huge advocates because we like the ground roots thing that you were talking about, Peg, is that we believe our nursing experience also is a much added value that really broadens and closes that experience out. So you may see PAs and NPs, and that may be sort of confusing, but I wanted to separate those two. And then to let you understand what we're really pushing for is this SAVE Act. And so we're writing our legislators, we're trying to tell our patients to write legislators, et cetera, like, come on, lighten this up. And our main people that do not like that are the physicians that want to continue to manage their what they are saying is their quality of care. But many physicians love NPs and are not in that spot. But it's been a battle in the legislature at this point in time. And we have a nurse practitioner actually in the legislature now that's a big proponent in trying to get that done with Gail Adcock.
Well, thank you for that clarification. And of course, PA stands for physician's assistant. So it is helpful to know that difference between the physician's assistant and the nurse practitioner. The next question also goes to you, Susan, not also, but since you've just been chatting with us.
Oh, chatting.
Yeah. How do you provide care? Tell me, are nurse practitioner appointments closer to the 15-minute doctor visits with a psychiatrist or a 50-minute therapy appointment? What does that look like?
So that's different for each provider. Some providers may choose to do a 15-minute. In my role, I do 60 to 90-minute appointments initially when I'm meeting with someone. And then generally follow-ups 30 minutes, but sometimes it depends on what the client's need is. If you're in a crisis that day, you're not going to go, well, time's up, we have to leave. You do what you have to do. Sometimes it's 10 minutes, sometimes it's 15. The idea behind it, though, is basically that you're listening to the person when they come in very carefully, as Angela talked about, and trying to conceptualize what needs to happen. And a lot of times they come in where either they're brand new to the system or they've been in this system a long time. So you're trying to track all of that information. And I think what we're really good at is educating and normalizing where people are and what's going on. Mental health stress is no different really than a heart attack. If you have heart issues, we just have to really reframe, re-educate, explain medications, how they work and why they work. And I think that's missing in a lot of psychiatry and mental health, is not understanding the larger system, not understanding the body and how it works with the body, how stress can manage the body, genetics, etc. So I do a combination. I think we all do a combination of therapeutic interventions. But if you really wanted therapy, and I don't do therapy on the week-to-week basis. I may see somebody monthly. I may see them every 2 weeks in crisis. But in general, if they're going to do therapy, I'm going to suggest certain types of therapies. We've all been trained on a lot of them, so we make suggestions of them. But that doesn't mean that I'm going to provide therapy per se. Plenty of people come to us that aren't on meds. We're not like med pushers. The reason probably all of us are in it is because we've seen how meds can be harmful as well as helpful. So I think that the medications are a big part of that, but I'm not going to not see you if you don't do medications. I want to be able to be with you as a collaborative person in your care to figure out the big picture with you.
I have two thoughts in response to that. I love that explanation. One is, I think this is the first time I've heard a mental health professional of any type say meds can be harmful as well as helpful. And that's true. I think that's great. Just that acknowledgement. It feels like a breath of fresh air. The other point is I love the acknowledgement of that need to normalize mental health and encourage people. I've been with NAMI a number of years, and I knew a family in Ohio that they just didn't want to do meds. They didn't want to do psychiatric care. They had their son, they took him to an exorcist. They changed the whole family diet and avoided any kind of additives and preservatives and certain food types. And I did the same thing myself, not wanting to do meds. And I jogged and I took St. John's Wort and I meditated and I joined Toastmasters. So that kind of thing is so important. You can save years of pain. LaTanya, Angela, do you have a follow-up?
And I just really again agreeing with Susan. I love the approach with just giving that person what they need in the moment and just being there for that. And our day as a psychiatric nurse practitioner, it can, you have to have that level of flexibility. You kind of never really know what the day is going to bring, but you need to go with it. You need to be there for your client and with what they need at the time. So I love that concept.
And just to follow up with what Angie and Susan have shared, whenever someone comes to us for help, that takes a lot of courage. Mm-hmm. It takes a lot of courage for someone to be vulnerable in that way and let us into that space. So we very much, as they have said, see it as a partnership, as a collaboration. And I often will tell my patients that I can make the recommendations and they're coming to me for my expertise, but at the end of the day, it's their treatment plan. And so hopefully they'll follow recommendations, but if they don't, we still accept them in a non-judgmental way and continue to partner with them to help them get to a better place. But at the end of the day, it's their treatment plan.
Okay. Well, that's a beautiful thing to hear as well. So LaTanya, first, and I'm sure you all will have slightly different answers for this question. Tell us about your typical patient, if there is such a thing. Do you see a lot of depression and anxiety? Are folks hearing voices, having manic episodes? What do you see?
All of the above. And I say that I think it's really important for us to remember that mental health exists on a continuum. And thinking about that, we've all struggled with anxiety. We all struggled in some way with something. And so things can be situational. And other times you may have a person that has a severe and persistent challenge, say like schizophrenia and other mental health diagnoses. So in a typical day, I literally can see patients that are seeking help for all of the above. But one common thing that I see is that at baseline, someone is coming to us to help with the alleviation of suffering. And oftentimes another piece that I see is that there are challenges related to social connectedness. And so if you were to ask me how many of my patients have this diagnosis or how many patients have this diagnosis, I like to look at it as more of how many patients are coming to me to help them with their challenges, with however you want to phrase it. 100% are coming for that. So I'll turn it over to Susan or Angie if they want to answer.
That's wonderful. I want to jump in real quick
Okay.
and mention that you've given me an entree to mention that NAMI North Carolina has a wonderful array of virtual support groups and classes completely free on our website, naminc.org. And I'm sure that link will appear in the chat box shortly. But free classes and support groups, you can connect with other people, whether you have the challenge yourself or you're a loved one, a friend, a family member. We also have a community inclusion program that speaks to exactly what LaTanya just mentioned, that folks feel isolated so easily and need help feeling a part of, and that isolation has the same impact on your mental health, on your overall health rather, as smoking 15 cigarettes a day, according to a report that was headlined in the Washington Post within the last 6 to 8 months. Maybe that'll appear in the chat box too, if I'm lucky. Angela or Susan, comments?
Well, with my population, I do tend to see more children, adolescents, and I manage a lot of, people that have some challenges with anxiety, depression, and significantly safety. I've seen that, it's always a factor that we need to evaluate for, and risk factors, safety planning, but certainly in the last year that's become more prevalent. The acuity has been there, and it's been a huge challenge. And going back to that concept of isolation, it is, we've seen so many struggles with maybe child with ADHD that has so many challenges engaging in virtual school, that now we're seeing anxiety, now we're seeing depression, families struggling, parents struggling. And so a lot of what I also do as the kind of concept of the care for that person in the family where they are in their community, and just kind of reaching out. I do a lot of reaching out to teachers, therapists, and collaborative care, which is so important. And, I'll often turn around and say, how are you doing, Mom? That's so important, because that person's there taking care of that child, the family, under immense stress. And it's important that we take care of those caregivers as well, and that they can have trust in us as well. So it's a very dynamic role, and you've got to consider the whole person and their family to be able to take care of that person.
I'm sure there are NAMI mommies in our virtual studio audience that are saying, yes, thank you, and NAMI fathers as well.
I say ditto to both. Ditto to both. I see it all, same thing, ditto, ditto, ditto.
Okay, wonderful. Well, thank you. Next question, we'll start with Angela. What do people need to know about psychotropic medications that they don't seem to know typically?
This is a big one. I'm glad that Susan has already touched on this subject, that, I often see people that may already be taking some psychiatric medications, and often people are not really sure the diagnoses or why they're taking it, what to expect, short-term side effects, long-term side effects, other options, other treatment options. And so it is so much in our role as providers to get true informed consent. And that means helping somebody understand their symptoms, any diagnoses that you're presenting or discussing, the complete array of treatment options. So medications, therapy, supports. It's important they understand the risks of treatment as well as non-treatment. If we're going to be given medications or talking about medications, that person needs to understand what they're doing, what they're targeting, any side effects that might be associated, monitoring the need for follow-up. We need to really empower the people we see so that they can understand what's happening and how they can help themselves and keep themselves safer in the context, especially of psychotropic medications. And the other side of it I often see is that sometimes there can all be preconceived ideas about medications that aren't necessarily based on the evidence. So we really need to come in and provide a lot of education about our medications and how they may help according to the literature and the evidence. So, for example, in my population, sometimes just the mere concept of Prozac is very, very scary and can bring a lot of questions for a parent. And so in that circumstance, you absolutely need to give the evidence base reason as to why you might be suggesting this and talk about the research and the medication. And often with adolescents, I will often go down to the talking about serotonin and what's happening in their brain and the structures of the brain. And so that information can be very powerful to the people that we're treating. And people deserve to know what's happening to them and deserve to know the treatments that we're given. So I think there's a huge need here for education. And certainly I know that the psychiatric nurse practitioner is well poised to provide that education and support.
Great. Other comments? Thank you for that.
Ditto, as Susan said earlier.
Ditto. Yeah, you nailed it.
Yeah.
All right. Well, good. I see we don't have a group of stage hogs, so that's good. Okay. What have we got next on our list? Susan, how has COVID-19 impacted your folks who live with mental illness?
This was an interesting question. I kind of, I've thought about it and I had one answer and I've changed it in the last 30 minutes. But initially what I saw was people that I had seen for a long time were faring much better than the influx of people that all of a sudden had not been presented with challenges that they had to overcome and figure out. People that had had mental illness for a long time have learned how to adapt and kind of move. Like I was always surprised. I thought that in the beginning I was had to do everything Zoom. One day I was in the hospital and Monday I'm on Zoom. And I really thought that I would just see people devastated or frightened or worried or anxious. And the people that I had been seeing for a long time really were kind of in a good steady. They were like, nope, I'm good. Nope, I'm good. I've got this. They just knew how to adapt in some ways to it. I will say that over time, and then a lot of new people have come into the system now, a lot. And whether it was built up and this was the tipping point, whether it's now virtual and it's allowed people a lot more access than what they would have normally done or been comfortable, I don't know. So there's a lot that have come in. But what I have noticed now is the people that have had long-standing issues are definitely suffering more with the isolation, the things that we want to tell them to do, to get out and exercise, to go interact with other people. The things that you normally do for your mental health have really been limited. And interaction now has been on the computer. And I will tell you, I think I've had more people upset over the country and what's going on in the country almost more than they were with COVID. It's extremely triggering on many, many levels on the way people talk to one another on the computer or talk to one another on social media. So there have not been very many distractions off of the computer and social media. And so I would say that that's caused a tremendous amount of an uptick. And Angie brought it up earlier, kids in school on Zoom and everything they're seeing that's coming. I mean, there's no delineation that's needed or necessary. So, interestingly, in a lot of ways, resilience shows up still for people that have it. And then in other ways, I think the thing that is not been it is about COVID, but a lot of it also was a lot of angst over the last 6 months in the country. I've seen a lot of that.
Right. It makes sense to me that response to the social unrest and the violence is more disturbing because there's more this issue of intention. If we're battling a virus, theoretically, that could be something that brought us together, but it hasn't really worked out that way. Other thoughts?
One of the I completely agree with that. Your observations and what you've seen, and then a concept I've seen with some of the children is that there's a little bit of a knock-on effect to where you may have seen, you know, a particular child for, say, ADHD management. Now there's brother, sister, or mum and dad asking for services. So we've had a huge increase in services. And, you know, again, that comes down to access. You know, we are probably busier now in the clinic than we've ever been. So I think that there's been a big knock-on effect within families and communities that we've seen with COVID, and then the social unrest is just been huge. And one thing with the adolescent populations is that installation of hope. You know, when many have had graduations that they can't go to or are very different, and they're not able to have spring break, or many of the things that they would normally traditionally engage with, they're not able to do. And this is now the second set of high schoolers that will not have a traditional graduation. And so there are many things that have had to be different. And so we've got to work really hard. I've found it to be particularly challenging with the adolescent population when you're launching in life and, you know, trying to find your identity, but you've got so many limitations. So it's been challenging for sure.
Yeah, that graduation piece is exactly what came to my mind as you were speaking. I have a friend with one son, and there was no graduation, so that was it.
Yeah.
Okay. Let's see. So LaTanya, next one goes to you. What do you wish your patients could do more of in terms of self-care?
Other than getting more sleep, more restorative sleep, I wish my patients could engage more in self-compassion, being kind to themselves, talking to themselves, treating themselves the same way they would a friend. And I think we could all use more of that, patients and providers and nurses. So I wish that my patients could engage in more self-compassion.
Boy, does that resonate. That just applies to myself and so many people I know.
Mm-hmm.
Thoughts, Angela, Susan?
Yeah, I would totally agree. And I've tried to myself reflect on some of the important education I give, and that aspect of sleep. I've definitely made that a personal goal, because I think, you know, for many reasons with our endurance, many nurse practitioners, healthcare providers have had to have significant endurance throughout this time. And so the importance of self-care, you know, nutrition, sleep, those fundamental elements in life that will take care of ourselves so we can take care of other people. So I remind myself when I'm given that education that that is important for me as well. And I've made sleep a personal goal.
I think I agree with what the other two panelists have said. Another thing that I would hope also is that they, over time, can feel more comfortable talking with people and find out that really they're not different from a lot of other people that are around them, that everybody's more similar than different. That's true for all of us. And but it takes a lot of courage to do that. And but I think that once we do see that, even when we do that ourselves, we end up being so much more relieved that it's, oh, I'm not that different, or there are other people that are in the same boat as I am. And that's what NAMI is so great at, is bringing people together so that they can share that and feel that they're not that unique or different. So that part of it is just a constant reaffirmation to them of like, you know, you're not the only person, but this is so, you know, how many people do you know with asthma? How many people do you know with diabetes? How many people? This is very, very common. It's just people don't have the outlets to be able to talk about it because of some of the challenges with the discrimination and stigma.
Exactly. Mental illness is not a casserole disease. You don't always get that community envelopment with love and people bringing you things and asking because they don't know what to say. They feel awkward. They feel concerned about saying the wrong thing. So they back away oftentimes. One of the biggest comments we get from people in our classes, our family to family class in particular, is I realized I wasn't alone. So that is a wonderful thing. Okay, so moving right along, Angela, people experience mental health challenges through the different lenses, depending on their perspective, also how the world sees them. Tell us about the impact of things like race, gender, and LGBTQ status on mental health and recovery.
This is a significant factor, and there's a significant impact regarding gender, race, and LGBTQ populations in relation to mental health. Generally, the data tells us that generally there can be poorer outcomes associated with these populations. And then when we look as to why that might be, there are challenges with discrimination, stigma. Often there could be limited healthcare resources, and then also that help-seeking behavior. There can be a lot of fear associated with seeking help and some of the judgment that may come with that. I see with the adolescent transgender population, particularly, there can be significant challenges, and the actual research shows us that if there's about a 40% increased rate of suicidal ideations or behavior when the people do not feel accepted. When there's acceptance, that reduces down to about 4%. So it's really, really important that these people have a safe place to go where they feel comfortable and they can seek the help that they very much need. There can also be people that can have secondary, can have, LGBTQ populations, maybe part of a second group of people that are marginalized. So you've got to also think of people in much higher risk factors as well. And again, there can be such fear and discrimination, and that limits the care that they are provided and limits their help-seeking behavior as well.
Right, and that's why NAMI and many other organizations try to extend ourselves and wrap our arms around those communities, because we oftentimes need a family of choice. If we're not accepted at home for whatever reason, or I'm thinking mainly of the LGBTQ community, you can find someone who will let you in and have that acceptance and support that you need. Other comments, Susan and Latanya?
Do you want to talk, Latanya?
No, go ahead, Susan.
Angie and Latanya just put on a really good conference for the nurses that you'd heard us talking about earlier. And one of the things I learned, maybe even from Angie's talk or Latanya, I don't know who was doing the talk, but I thought was really interesting too, is a lot of the research that we have in mental health, maybe it was your husband even, Angie, I can't remember, but all the research that we have in mental health in general has been in white populations. So where we are doing the research and where we're educating people, we've not been inclusive in the research aspect of things as well to that. And we don't have as much data and the understanding of the layers and layers of weight to be in one of the communities that you're discussing is a whole different level of weight than possibly white privilege and the way that that is managed and the way the research has been done for that. So there's even more than the day-to-day, and what they have to handle is we don't even have a lot of the data and research to be able to give them and support them in the way that they may need it. So fortunately, I think a lot of us are beginning to wake up a little bit more and learn more and garner more, and there's going to be more funding into the research that exposes that. But it's definitely another aspect that needs to be thought of, and I've never really, that goes back to what my assumptions are. But I learned a lot in that aspect, like how to, that's like saying where we learned on COVID, how many people and how varied was the data even on the vaccinations, and how, what types of populations did we garner, et cetera. So these two ladies have taught me that in the last thing that we have done as far as what they presented and how they brought that forward to our groups of psych MPs.
It's wonderful. Latanya?
So to piggyback on what these ladies have said, there was an article that talks about why evidence-based practice hasn't really impacted healthcare disparities. And to Susan's point, when you consider the evidence and the research, oftentimes marginalized communities are not included in that research. And then when you take into account whether it's explicit, implicit biases, the different ways that we see things from our perspective, confounded with things like racialized trauma. If you layer that on and then add on top of that some kind of mental health problem, that's just confounded. And so that presents these layers that we have to go through to try to help the patient, get to the patient, to assist them. The other part of it is that whether it's race, gender, LGBTQ, we have to remember the patient preferences and values. And so with that evidence-based piece, that's part of that, the preferences and the values. So again, like we've been saying all night long, we have to bring the focus back to the patient and provide that strength-based, patient-centered care.
Well, it's so heartening to hear all of you put so much emphasis on the patient perspective and what works for them. And it is a challenge too, reaching these communities, because some of them have been traumatized or felt rejected by the system that's designed to help them or designed to help someone. So yeah, it is, I think, an area that needs some emphasis moving forward. One more quick question. I just noticed the time, but I don't want one of you to have fewer questions than the others. You can't do that. So Susan, what does your most challenging day look like?
Well, I'm not going to talk too long on it. It's generally not about the patient that's the challenging day. It's the system that we have to interact with that's the challenging day. So I put things like putting children in handcuffs when they're committed in a hospital to have to go to another hospital and watch them drive away in a police car, or where there are adult children with significant issues that will not allow you to talk to their family, yet their family are their broadest support system. And with HIPAA laws, you're not allowed to really do that unless it's safety. But there's so many other issues that would be better with the whole family involved in treatment. That's been hugely difficult for families. The other thing is I think all of us will talk to this, have learned more and more about trauma and trauma-informed care, and the system does not have that as a whole. It's very piecemeal. Maybe a provider will understand that, but the entire system is not trauma-informed. And many people have had trauma in multiple ways, and whether we're re-traumatizing them by the system that we have, even though we're trying to do differently. The challenge comes really in the system issues to me, more than the actual patients or what they do. They're the strong ones, the resilient ones, where I'm having a fit over something. They've become used to it, and that just fires me up more than anything else. So a challenging day is interacting with a system that is not supportive to the people that we're trying to support.
Well, that makes perfect sense. Any thoughts in follow-up, Latanya, Angela?
I thought that was well said, well stated, and agreed.
Okay, well, let's move along then to our video of the week. We're going to move on from the interview portion of our show. And first, I want to do some quick shout outs. Our fabulous interns, Patience Greg on Chatbox, Eddie Simmons on tech. Thanks to Gail Pruitt, our psychiatric nurse, who's helped us set up tonight's program. Executive Director Gary Kreitz for always being here. And to those in our audience, the students from NC State and NC Central, we're so glad you're here. And finally, thanks to our esteemed guests. Appreciate you all so much. Our video of the week is usually something a little bit lighter. We talk about heavy topics here on Thursdays with NAMI. So this one involves a dog who was lost and needed rescuing on the cold but very beautiful mountains of Ireland. I just love this video. I hope you enjoy it too. Here we go. Kind of a sweet little story, a little bit of a tearjerker. In case you're wondering, as I did, why did the dog run off? It was chasing a deer. And so the family got it back. Everyone loves a happy ending. Okay, now virtual studio audience, it is time for your questions. If you are new to Zoom and aren't familiar with how to ask, please click on the Q&A icon at the bottom of your screen, type the question, it will magically be delivered to us. All right, and we've got one right up here. If you were speaking to a group of young persons who had just been certified as psychiatric NPs and were starting this new stage of their careers, what advice would you give them both professionally and personally?
I think I would say take a really deep breath. You're not going to have the answers. Walk out of the room and say you need to go check on something if you don't have the composure to manage what you just heard or seen, and lean into the other people that are there. And when you've had a hard day, let everybody know, or your support system know. But you're not going to know all the answers at all, and you're going to be freaked out, and it's going to be scary. But ultimately, what you really need is the relationship is 75% of the event. And that's what you work on. Don't worry about the other stuff.
That's great. I've never heard the relationship being 75%. It makes perfect sense. And I like the candor. You're going to freak out. It's okay. That's normal. Mm-hmm. Other thoughts?
Agree with Susan, and to go with the flow as well. You know, you can't go in with a preconceived idea of, you know, well, I start clinic at 8 and my last, you know, client is at 4. You know, it is what it is, and people present with very different challenges, and you might find yourself in a crisis situation that you just need to manage. So I would talk to the clinic or front staff or whoever you're working with to have a system that when inevitably things don't go as expected, there's a plan for that. So, you know, if you need help, if you need another opinion, if you need somebody to watch the front door, if you need something to happen to ensure safety, you've got somebody there that can do it. And you know, we've got an internal system, and many offices have this, where you can talk to staff members by typing, and so you can communicate. But I would have these systems in place, so when you are in a crisis situation where you are needing that support, you've got mechanisms to do it, so you can keep certainly the client safe, people in the clinic and yourself safe, and so you can you know, get them to the level of care they need. So just be prepared, think about those things, talk to staff members. Communication is super important, and have some plans in place for when these things happen, and to go with the flow. You can never predict your day at all, but certainly be prepared and do the best you can to manage situations.
So we do what we do because we care and we want to help. And so I think it's really important that you don't get in your head that you're trying to fix anybody, because if you put that burden on yourself, inevitably you will fail because it's not your role or your job to fix anybody. It's your role to come alongside, to help, to listen, and to be present. And remember that with each interaction, you truly make a difference just by being there and offering yourself and trying to help. But don't get it on that hamster wheel of trying to fix people.
And the last thing is, it's such a privilege. You are walking into such a privileged, beautiful space, and and make sure you remember it's a privilege.
That's right.
Wow. I want to go see you all next time I'm needing some support. I've got that on my list now. So, next question from Gail. How would someone who is seeking help find a psychiatric mental health nurse practitioner?
I think, you know, the power of Google and just researching and sometimes word of mouth. I think that, you know, it is important as well to maybe find out, you know, again, like anybody that there's a good fit, you can certainly research somebody's history. But I think that, you know, we can be tracked down, so we can certainly use the internet to your advantage to find a nurse practitioner.
I've seen a lot on Psychology Today, the www.psychology today, and it says therapist or psychiatrist, and nurse practitioners may be in either one of those loops for people, actually. That's not all of them, because a lot of people don't subscribe to Psychology Today, but that's the beginning of it. But we've talked about doing we've talked for years about trying to come up with a database of just psych NPs. And I agree with you, Peg. A lot of people want to find us, but it's hard to find us in some of those ways. LaTanya, do you have any ways?
Well, I think about where I am, and some people are driving up to 2 hours for care. So it's hard enough to find us, but then people are having to drive depending on where you are in the state. And I know in my clinic in particular, people are unable to self-refer. And so they have to, like, oftentimes go through like a primary care provider or some medical provider in order to get access. But to your point, and the whole point of us having this conversation has to do with the shortage. So unfortunately, there aren't enough of us to go around, and we're advocating because our patients deserve, our North Carolina citizens deserve no less to have more of us to serve them.
And any psychiatry clinic may have NPs in it. So you could call a lot of the psychiatry clinics and they may have PAs or NPs, not just psychiatrists, but the clinics are getting bigger and bigger. Obviously the big hospital health systems might have psychiatry groups. There are not that many NPs like in the School of Medicine as a psych NP, but like there are certain larger groups that may have them. You could specifically ask for the role within a psychiatric group as well to see if there are any in those.
Okay, so we've got a question now from a family-to-family teacher. In her experience, one of the biggest challenges during COVID is finding a mental health professional where you have access and it's a good fit. That's a big challenge for her folks. Any suggestions? I think find a magic wand would be step number one.
The other thing that I do to complicate it for parents and kids is, in order to get an adolescent engaged, because many do not want to be engaged, I ask them to interview 3 different people. That means 3 different phone calls, 3 different, you're going to have to dump it all out. And of course, this is if the family's willing to do that for resources, but it buys engagement on the teenager that they've chosen this person instead of you're forcing me to go to this person, etc. I understand that what we're asking is there may not be a lot of providers to it, but my suggestion, I think it'd be even easier in some ways now that it's virtual. You could go anywhere in the state if you wanted to. But that you could, the point is, in the teenage population and the adult population, if they're feeling connected with certain providers, they know what that feels like. That should be the same way with a therapist, if not even more important. So my suggestion is, just like you would go get a quote from a car mechanic, I think it's reasonable to do calls and quotes and ask for certain things. What's their experience level? How often do they treat this? What do they do? And sometimes you're going to be able to get that feel and fit, which is so important, even if you have to look for it.
And I think it's okay to move along as well. I'll see people that have had a therapist for years, and I'll say, do you think it's beneficial? And they'll say no. And, with adolescents, what are you working on? I don't know. And so I think it's okay, again, to give options. We need to always give options. And if this is not working out, let's find a way that we can find a service that can work for you. And then perhaps identify why, or identify barriers with the current situation that may need to improve. But it's okay. I tell my people, just, tell me the way it is. That's what I need to know so I can best take care of you.
That's a good point too. It's, people are people. You won't always have that ideal communication and chemistry with every person. It's just not how we're built. Any other comments before we move on? Okay. So Angie, are you able to give a 2-minute version of the story you told at the psych conference and how you helped the young boy get the help and treatment he needed to lead his best life? He was written off by a school system as not worth the effort. Ouch.
Yeah, I've just given this, and thank you for asking me to do that. It comes down to, I was talking about ADHD and discrimination associated with ADHD. And while we find the prevalence of ADHD across cultures and populations is the same, the identification and diagnosis and treatment is not. And what we generally know within the literature is that Black children and Latinx children are not diagnosed as readily and not provided the essential services they need. And so I talked about a little 8-year-old Black boy that come to the clinic, and he was living with his aunt, and he was already scheduled with the clinic, but his aunt came in very frantically asking, could we please see him, because he was about to be thrown out of school, sent to an alternative school, and she didn't feel that he needed to go through that on top of some of the challenges he'd already encountered. And so we saw him, found a spot that day. We saw him that day. I just want to mention, that's that flexibility part. You never know what your day is going to bring, but you take care of it. And so when I was engaging in the evaluation, he was just a delightful, lovely little boy, and he was looking at me. He was apprehensive, and and I was thinking, what could be so challenging with this child was about to be thrown out of school. And so what his aunt described was very typical ADHD symptoms, not listening to the teacher, being disruptive, talking. And instead of that system working with him, maybe identifying the problems with attention, focus, and hyperactivity, impulsivity, it was taken in much more of a context of behavior, which sometimes can be associated with Black children and limitations in relationship, versus this is the most prevalent neuropsychiatric disorder that's exceptionally treatable. And so they were going down the road of finding an alternative school, and at the time they were only allowing him in school for 30 minutes a day. And just what that message that was given to that child is just unbelievable message that must have been given to that child about his level of acceptance. And so, I engaged in evaluation, diagnosed him with ADHD. I sought appropriate treatment, and we immediately saw a significant improvement. He was much more able to manage his behaviors and the symptoms because of the huge benefit of treatment of ADHD. And then he slowly went back to school, an hour, 2 hours, morning, afternoon, and he's been back at years and doing fantastically well. But it was exceptionally sad that there was the judgment on this child and just the readiness to transfer him in the system, getting lost in the system at such a young age, versus seeing that child in the context of what was happening, the symptoms, and treating him appropriately. And it's, whenever I see a case like that, and it just makes me so sad. And just to think what difference it made to his life by treating him versus allowing him to get caught in that system. So I appreciate the opportunity to tell that. And it's just so fundamental for us providers to be able to see that person, see what's happening. And then the other thing is educate the school. You know, I had to work with a 504 plan for that child so that he could be successful in school, and there'll be greater understanding of behaviors than certainly what was happening when I first met him.
Wow, I do appreciate that question, Gail. And if you think of that child's life as a timeline or as a decision tree, just think of the difference you've made from that point forward. That's a beautiful thing. So Susan, LaTanya, do you have stories, thoughts, insights, good jokes in response to that?
No, that's always a good story. I love that story when she told it before. There was a question that you had talked about earlier, like what gives us hope, or maybe what's a book or a movie or something like that. Certainly what gives me hope, I've been in this long enough now to actually see remission of people. People can live with a better quality of life. Treatment works. Remission happens. It isn't crisis all the time. It can, even some of the sickest patients that I've seen are okay, got a good quality of life. Things are moving on. So life is not stagnant. It moves on. The one thing, and then I think I touched on it a little bit earlier. Fundamentally, one of the best books that I've read that I use all the time, that is very comforting to a lot of people. A large amount of people that come to us are traumatized, and this is particularly for adults, and with developmental trauma, where they had a lot of abuses as children and had to be extremely resilient to move forward, but were unable to establish relationships as children because their life was chaotic, fearful, etc., or they were being abused quietly for a long time. Anyway, I think developmental trauma is something that's not discussed, or it can be called chronic PTSD or complex, etc. And there's a book that's called How the Body Keeps Score by Bessel van der Kolk that's been on the New York Times bestseller list forever. I think that when I can describe that to many, many, many people that come in, that's a huge part of the evaluation. There it is. That is such a relief to people to understand why their relationships have been poor, why their moods have been all over the place, why they may have been diagnosed bipolar when there was no bipolar in their world. I mean, it is a book that is extremely useful to as many patients as it has been to me to validate. There's only one medicine that is even in that book, which was Prozac, which that psychiatrist doesn't believe was very useful for all of that. So it's understanding the conceptualization of trauma. We all need to talk about it a lot more. We need to know what trauma-informed care is. We need to understand dissociation. We need to understand all kinds of things that are out there that have not been taught. And we really don't treat diagnoses, I would say. Nurse practitioners are good at working with symptoms. Diagnoses are for insurance companies. And for us, the symptomology can be so intertwined in so many different diagnoses that I think understanding trauma gives people a sense of understanding. So I think that's that's just my little added thing that has been, I think, very, very useful for many, many of my patients.
Yeah, that was a question on my original list that I sent to you all, and I don't always have time to get to all the questions, but you're welcome to answer them now. I'm not seeing questions in the Q&A box, so virtual studio audience members, you are welcome to ask. We're going to start kind of wrapping up though, because we do go with the energy of the group and the energy of the questions as they come in. So any closing thoughts from our panelists?
Just in agreement with Susan, it's the people I take care of that honestly give me most hope, see their courage and strength, and the ability to have that human experience with them. That is, it is, like we mentioned before, it's a privilege. It's a fantastic role to have, and I get a huge amount of encouragement and hope from the people I take care of. The other thing is the advocacy piece is so very important. And as an educator as well, it is so critical for us to be able to get out there and educate other providers to be able to take care of people. We need to do that. And it is very empowering to help other people advocate for this very vulnerable population.
Thank you. Yeah, that advocacy piece is always so important. Tanya, you look like you have something to say. I think you're muted.
Going back to what Susan and Angela have shared as far as the hope, anytime when you have the opportunity to partner with the patient and you're able to see them heal and to see them get to a better place, that gives me so much hope. But another thing that gives me hope, I will have to give a shout out to some of the nursing students that I've encountered who thankfully they, unlike some nurses who may want to stay away from mental health, there are some nursing students and nurses coming up that are interested in mental health, and they have a passion and a desire to help with that healing process. And so when I see the nurses that are and the nursing students that are coming to join us in what we do, it's exciting. So that gives me hope.
Wow. Well, I'm certainly uplifted by hearing all of your perspective and your thoughtfulness, how much the patient is at the heart of all that you do. So I'm very grateful to our guests, LaTanya, Angela, Susan, and thank you so much for all of that. I want to say to members of our virtual studio audience, thank you for joining us tonight. Please do the survey that pops up when you close out of this screen. It helps us so much to improve over time and to show to our funders the value of what we do. It's very, very helpful to us. Please come back next week. We have Coach P, AKA Joanne McCallie, who is the former women's basketball coach at Duke University. She's written a memoir called Secret Warrior, detailing her personal experience with bipolar disorder. So if you wonder sometimes what peers can achieve when they take care of themselves and manage their illness, this is a wonderful example. Coach P is a big, big name on the college elite basketball scene. So I want to give a final opportunity for questions or guests. If you have any closing statements, I think you've all said wonderful things. I always feel like I don't want to rush anybody, but apparently I'm not doing that tonight. All right, well, another Thursday evening has flown by. Thanks so much, everyone, for being with us tonight. Whatever you do this week, please be safe, go where you need to go, do what you need to do, and take care of yourselves. So thank you all so much. Have a wonderful night.
Good night. Thank you.
Thank you.
And I'll be in touch with our recording information and our survey results. So thank you so much again. Good night.
Good night.